Probably rested too much. I'm a bum. Let me bring this up so you can see it. So under the cancer stuff under 1B, if you look here, can you see it?
Yeah.
So I got these together. So I started putting the stuff together. And some of these I kind of paraphrased them. So like if you look here, benign tumor, it just suffixes ulma. We all know benign tumor is not aggressive. It's not going to move. It's just a encapsulated tumor that's not dangerous if we can still deal with this. And then malignant tumors are epithelial based, and their suffix is carcinoma. And clearly, they're mostly found in epithelial layers. Excuse me. And then malignant tumors are mesenchymal, and they're the most common in connective tissues, less common than other cancers, but very aggressive. And the best treatment is radiation. And then if you go, I'm at the bottom of it, not the top. Okay, so just go to the top. The vocabulary 1 through 4 here in the definitions. So I kind of paraphrase these because they're quite long, some of the definitions. And I thought, well, we know what some of these are. We don't need the whole freaking 8-line definition. So malignant cells have no differentiation was the vocabulary that I put. They all look the same. Okay. And then contact inhibition, healthy cells know to play well with their neighbors, right? They know that when there's a neighbor next to them, not to crowd them out. Cancer cells don't do that. They crowd other stuff out. Cohesive normal cells are happy. It should say cells are happiest when they stick together. So when muscle tissue is next to muscle tissue, it's happy. When it gets removed, it dies. It doesn't like being alone. It likes to be with somebody else. Anchorage independence means that healthy cells, they like to be attached to basement membrane. Cancer cells do not. They don't care that they're attached. And then 5, faulty cell-to-cell communication. Cancer cells don't get the signal from neighbors to stop growing. So that process is broken down in them, and that's what causes cancer. And then antigens or antigens on cancer cells, they're antigens, they're placed in their cell membranes, and they're used to identify them. So we can use them to identify them, but that also how they identify each other. Just like any cell, they have that, but they start to put new antigens on their cell membranes. So they start as lung tissue. They start to become malignant or cancer, or they get benign. Any tumor starts, the normal antigens that say, hey, we're normal lung tissue, die off or get removed. And the cancer cells start to put new ones out there that tell, hey, we're cancer, we changed something. And so they start to do this. And then enzymes, cancer cells secrete enzymes that change their environment, right? They change the intercellular environment to make it more conducive to them and less conducive to the healthy cells. And so that's another thing that cancer cells actually do. They secrete enzymes that make the environment more conducive for them. And then the 3 that I just put down. So I'm starting to work through these ones here as a review. And so if you want to look at them, you can. Or if you want, I think you already started adding stuff. I looked at on here, and you started already adding. You started adding stuff already in here. I saw you put some in here already.
Yeah, for the.
Yeah, there's a one. I'm not sure if we. Okay, there we go. They're coming up now. Maybe I overworked it. Like you already. Okay, so you started it, just nothing's in there. So we're thinking the same thing.
Yeah.
Okay, so I'm moving on those, and so just so you know, start looking down there. And again, we had a pretty good review. We started reviewing in the other sections because the next test in class is a midterm, and so it's everything up into and including Unit 8, but it's also 1 through 6 as well.
Yeah.
So she reminded me of that. So we still have about 2 weeks. So let's just be aware of that as we're moving forward, that we're looking back as well. So but for the here now, I'm going to turn this off. We can get into this, and we will, yeah. So we can get into this and start. So yeah, we can go over this. I'm just going to do whiteboard style. So if you go to Unit 7, right, the one we're working on, let's start breaking these down because there are some parent ones. And so let me see. So go ahead and start looking through here. Starting on page number, starting on page number 3, can you tell me what the first parent group is?
Yes. Let me. Okay, so the renal dysfunctions, is that what you mean?
Renal dysfunctions is the main one, right? It's the overriding one.
Yeah.
And then the next one, so if you go to page number 5, there's another main one there.
Glomerular disorders.
So looking at the titles of those, looking at renal dysfunction and looking at glomerular disorders, when you hear those, what do you think those cover? So when you hear the word renal, what does that mean?
Kidney.
Well, it means anything in the urinary system, right?
Yeah.
Everything from peeing all the way up to the blood supply coming into the kidneys.
Yeah.
Covering, it could be anything across the whole structure. Now we know you're looking at the individual disorders in there. Urinary tract obstruction, that makes sense then, because what does urinary tract obstruction look like?
With the urine.
Well, so let's read
like
it.
With the bladder.
Yeah, so it says, okay, listen, urinary tract obstructions are most susceptible are males, genders aged 20 to 40, living in a desert or tropical region, prone to dehydration, inadequate fluid intake. You know, they're drinking alcohol or whatever. No modifiable risk factors for all these is dehydration. So urinary tract obstruction, it's kidney stones. That's what it is. So it's a physical obstruction of at the renal pelvis, near the top of the kidney, all the way down through the ureter. So that's urinary obstruction. Okay, let's look at the next one. So if we look at the next major one, what's the next major one? The one that's most susceptible to women.
The UTIs?
Yeah, so UTO is male, UTI is female.
Female.
Driven. And then what's UTI then? You tell me.
Urinary tract infection.
So if UTO is starting at the renal pelvis and moving towards the outside of the body, what's the difference between UTI?
And UTI is from like basically out or down, outside, moving up.
Moving up. That's the way we kind of work through remembering those, how they're different and whatnot. And then obviously UTOs are driven by mineral formation moving down and causing obstruction. And how does what's UTI's base start?
From the outside.
No, because you guys have yeast and certain bacterial and stuff going on in your orifices as females that normally are totally in control. What happens to those?
Well, it's normally with like the urethra.
What I was looking for is opportunistic infection.
Okay.
You don't normally get an infection with those, but what happens? They're opportunistic because they're always there and something changes. So the immune system stops working to keep those in check. So taking antibiotics, maybe having another different infection somewhere else in the body that the system has to fight, and then the immune system just says, screw it. We can't deal with this, vaginal yeast. We're going to just move on to what we got to go fight strep in the lungs. You know what I mean? And so it just says, forget it. And it moves on and says, we'll get back to that later because it's not as big a deal. Or like we talked about, older ladies who don't clean themselves and don't take care of themselves or don't drink enough water, they start to develop things. So it's opportunistic. But it's best where UTO, it's not opportunistic. It's like a kid not drinking enough water and working out in the yard too much.
Yeah.
So again, it's not an opportunistic issue. It's more of it's a hard structure buildup.
Yeah.
Okay.
Okay.
Okay. What's the next one in that group then?
Causes obstruction.
Moving on to the next yellow thing, the next yellow one, the big yellow word.
The pyelonephritis.
Yeah, so pyelonephritis. Now, looking at the two above it, now we can kind of remember what pyelonephritis is. What was it? Without looking at the notes, we should be able to remember this.
It's the let me think about this. Well, isn't it just doesn't it happen with the backflow? Yeah,
it's a bacterial-based infection, right? It starts at the urethral opening and moves up. So UTIs do not move up. UTIs don't move up. They're in the orifices leading out of the body, right? But they don't move anywhere. They're staying there. So UTIs progress to what?
The pyelonephritis.
There it is. And so we started making these associations, right? So you cannot really have pyelonephritis without what first?
Without a UTI?
You're going to see a UTI first, and then it can progress to pyelonephritis.
Okay.
So these were the associations when you weren't there. We started making these associations. And so can you see my book, my paper, my thing?
Yeah.
So that we started doing it like this.
Okay.
So we had renal disorders and then UTO, UTI, and the two that were associated were UTIs and pyelonephritis. UTO is its own standalone thing.
Uh-huh.
You just got to remember it's renal caniculi, it's in men, you know, where UTIs is women. And again, we know that pyelonephritis is going to be a lot more common in women as well, just because of how closely associated it is, and that it leads, UTIs lead to pyelonephritis.
Yeah.
So we just spent like 10 minutes talking about that, and I think we pretty much covered it. You know what I mean? Instead of spending 20 minutes talking about the one and not really making those associations, we did that yesterday, and now we got that all done.
Okay, that makes more sense.
Yeah, so, and we can get in more to like flank pain and the different signs and symptoms, and we need to do that. What I'm saying is the time that we have left up to the quiz, I think this is going to be a lot more helpful.
Yeah.
Because let's be honest, all these have flank pain.
Exactly.
I mean, at the end of the day, most of the signs of the symptoms are like pretty much the same. Okay, so let's move on to the next one. So what's the next big yellow one after pyelonephritis?
Okay, the glomerular disorders.
So yeah, so glomerular disorders. So by definition, where do these all have to happen?
In the glomerulus?
Yeah, they have to be in the glomerulus doing something, right?
Yeah.
And if they're in the glomerulus, what's the major function of the glomerulus?
Isn't it where the blood is?
Yeah, it's the major filtering structure in the kidney.
Yeah.
Right? That is the major filtering structures. So without knowing any more than just that major name, we know it has to do with what? Filtration of the blood.
Yeah.
And then obviously urine creation. So as blood comes in, it's getting filtered. And as it leaves, it's leaving as filtered blood and as urine formation. One or the other, or obviously both are happening. And so anything dealing with glomerular disorders, we know we're going to be dealing with those things. It's either blockage of the glomerulus leading in, not letting blood get in there, which is letting it die, or it's like urine formation or breakdown of the glomerulus or breakdown of the DCT and PCT or the nephron loop, which is causing abnormal urine formation and abnormal blood products leaving the kidneys. And so so see what I'm saying? Without doing any more than that, we at least know that much just right there.
Yeah.
Okay, so let's talk about acute glomerular nephritis, the first one.
Okay, so that was
I just call it acute GN now.
Yeah. Acute GN. Inflammation of the glomerular membrane.
So remember, there's two types, right? There's
Group
A and Group B, or group primary and secondary. So what's primary?
Untreated strep A.
Yeah, it's just
Group
strep A.
Strep. Yeah.
So strep A. And then secondary was everything else. Drugs, toxins, you know what I mean? All that stuff. It's on the next page. So drugs, toxins, vascular disorder, systemic disease, diabetes, lupus, and then viral infections.
Okay. Yep.
Okay, so and again, we know what's going to happen. It increases glomerular membrane permeability, allowing certain structures to get through that would not normally get through, and it's caused by what?
Well, wouldn't it just be caused by the injury?
Yeah, well, strep A is an infection, right?
Yeah.
So if you get an infection, what's the immune system want to do to an infection?
Fight it off.
It wants to attack it. Well, how does it attack it? It attacks it by inflammation, and then it also attacks it by doing phagocytosis of foreign body cells or strep cells. Well, those strep cells, when they're attacked by a macrophage, are now 3 times as big as they normally were, and they cannot get through the glomerulus. They get stuck in there because they're in the blood. They get in those glomeruluses and they get stuck, causing all that damage.
Okay. So
that's what's going on. So it's in the acid immunoresponse table, ACID. It's I, which is immunoglobulin buildup, or step 3, and that's what's happening.
Okay.
Okay, so those foreign bodies are getting attacked by the immune system. They're getting surrounded by a macrophage, and they can't break them down fast enough, so they hit the glomerulus as full-size immunoglobulins, and they cannot move through there, and then it starts to damage those glomerulus, whether they get stuck and they're not getting some blood supply, or it's slowing down the flow of the stuff, or it's physically damaging the structure and busting this bust structure open. It's causing them to be damaged and not work.
Okay.
Okay, so that's that guy. So broken kidneys cannot filter or excrete fluids. So what's their primary signs and symptom?
It would be like
edema. Full body edema is the primary sign. Okay. And that's special to kidneys, right? Any other kind of edema, whether it's DVT, pulmonary edema, it's localized to one organ.
Yeah.
Kidney edema is the whole body's getting backed up.
Okay.
Okay. So that's that guy. So moving along. So now we have the two special words, nephritic syndrome and nephrotic syndrome.
Yep.
So under glomerular disorders, we still have nephrotic and nephritic. So what's between those two?
So nephritic is the loss of the blood, or a lot of.
And what else? If it lets blood out, it's letting something else out too.
With the blood?
Okay, red blood cells are large structures in the blood. If it's letting those out, what else can get out with them?
Proteins.
So proteins can get out because proteins are smaller, right? So it's like when you ever have a little change counter, if it'll accept quarters in that hole, what other kinds of change will it let through that hole?
Dimes,
pennies, nickels, right? Because those are all smaller. So proteins are smaller coins. So nephritic will let blood and protein through, where the other one, nephrotic, is only large enough for pennies.
Yeah.
So quarters, which are red blood cells, can't get out of that hole. Only proteins can get out of that hole.
Okay.
Okay, so that's the two of those, nephrotic and nephritic. Okay, and how much stuff do we have to be releasing in nephrotic? How much protein per day do we have to be releasing in nephrotic?
Just for protein, right? Or well,
yeah, how much total? Okay, yeah, 3.5 grams per day.
Yeah.
Okay, so let's move on. So now we have a brand new one is ATN.
Yeah.
So what's going on with ATN?
Well, acute tubercular necrosis.
So just look at
the lack of oxygen.
Necrosis. So where is this happening at?
To the kidney tissues.
Okay, again, kidney tissues is pretty broad. So is it the glomerulus? Is it the PCT? Is it at the renal tubule? Is it at the ureter? Where exactly is this going on? You can look at your notes if you need to. It's okay. I'm pushing you a little bit because we're Sunday.
Yeah.
We're Sunday. It's time. We gotta be. You know what I mean? Pop. But it's okay. It's fine.
Right here
if I push you a little too hard, just let me know.
The ischemia.
So it says here, right at the very bottom, underneath the name of it, ATN, damage to the tubular cells of the kidney, which can lead to acute kidney failure. Acute tubular necrosis is usually caused by a lack of oxygen to the kidney tissue. So blood or ischemia to the kidneys itself. The kidneys are not getting any blood at all. Okay, but the damage itself is happening to the proximal convoluted tubule coming off the glomerulus.
Okay.
Okay, so it's coming off the glomerulus, and because they're not getting any blood, we're getting weird pressure, and it's causing those tissues around there to break down. And then those tissues, those epithelial cells are flowing in to the tubule and blocking that tubule now. So it's a double whammy. You're not getting any blood, and now those tubulars are getting blocked. They're breaking down, and the debris is flowing into the tubule and blocking it.
Okay.
That's awesome.
Sounds great.
So if you have low blood pressure for more than 30 minutes, in the case of, like, say, a car accident victim who has massive bleeding, they're going to have low blood pressure for a while.
Yeah.
These guys are definitely susceptible to this. Septic shock can cause this. So anything that's pulling blood out of the system can cause this. Okay. Eyes, injury or trauma to the muscles, which releases those myoglobins. Those large myoglobin structures block blood getting into the kidneys. And then obviously blood transfusion reactions where you got A blood in your B, and it causes that immune response and those to clot up. And then obviously major surgeries where you're not moving around. You can have large blood products floating around that can do this.
Okay.
Okay. So, but we can treat this in the early stages. So say in 15 minutes, if we start pushing like IV fluids and loosen the blood up and keep the blood pressure up, it can help with this and keep this from actually completely destroying their kidneys.
Okay.
Okay. So the signs of this, so they're going to have LOC changes because they're not getting blood. They're not getting blood to their head. Okay. Oligary anuria. Those are low blood, low P or no P.
Yeah.
Whole body edema again is there. We're going to see that. Cardiac problems because they're having electrolyte imbalance issues because we're pissing off the electrolytes they need at the kidneys, or they're not, or they're getting reabsorbed and they shouldn't be. It's going to blow the blood. It's going to blow the blood electrolyte levels off. And then specific gravity. When we test their specific gravity, it's the same number for 24 hours.
Yeah.
Yep, they're toast. They're done. Okay. What's the next major one? The next part of the page.
Acute renal.
So yeah, renal failure is the overarching shell, and it covers two types.
The acute kidney injury, and then chronic renal failure.
So yeah, acute and chronic are the two major ones. Now, we know from the word acute, what does that mean for us as nurses?
That it's going to potentially get better.
Yeah, we can treat this, right? It's still at a stage that something can be done about it, whether it's the body's natural systems to fix it or we intervene, we do something and bring them back to basically full health, right? If you have chronic renal failure, what does that mean?
That they're screwed.
Well, they're not just screwed. It means that we're looking more at maybe a maintenance or palliative care, right? We're not going to bring kidney function back, but by doing certain things, we can help them have a better standard of living.
Yeah.
Okay, so let's talk about this thing. So what's acute renal failure?
So that could be like a trauma or
history of trauma,
anemia,
infection, right? They could have strep. They could have strep throat, and it could have done what? It could have moved down and become. I want to say it's pyelonephritis. Where are we at? Well, no, it's not pyelonephritis. It is. Damn it! I keep forgetting to here. I'm still learning with you. You know what I'm saying? What's the one that does strep A? It was.
Oh.
It was glomerular disorder, wasn't it? Yeah, glomerular. So primary acute glomerulonephritis is strep A. So if they had a strep throat, it could have moved down and become a glomerular disorder or acute glomerular nephritis. That's from strep A. So that could have been the reason. Okay, but we can do something about that, right? We treat the strep throat, and we give them a bacterial medication. It's going to potentially treat the infection in their kidneys as well.
Yeah.
Okay. So what about chronic?
Chronic, you would just like treat the like you said, it was kind of like I can't think of the.
It's long-term. It's long-term care or palliative care.
Yeah.
We're getting into more long-term care. We're not going to fix it, but we can make their standard of living better.
We can make it better. Yeah.
So I'm going to read this from the actual notes, and this I think will help you kind of feel this out. So in acute, we're actually doing things to solve it, right, to relieve it. In chronic, it says common problems associated with chronic kidney disease include alterations in fluid and electrolyte balances. Well, can we affect an electrolyte imbalance?
Yeah.
But yeah, by giving them IV fluids and medications with those electrolytes in them, we can get those back to normal levels. Disorders of skeletal, hematologic stuff, right? That's related to the vitamin D uptake. So if our kidneys are hurting, and they're not, and remember, one of the key functions of the kidneys is to help release and make vitamin D available to the body. Well, if they're damaged, they're not going to do that, and so the liver can't now use the vitamin D to uptake calcium. Well, we can give people vitamin D injections, and we can also give them an increased calcium uptake, and then their body will have more of an opportunity to bring calcium into their body to make their bones strong and to have calcium available for other functions.
Yeah. Okay.
And then it says hematologic, a decrease in erythropoietin. Well, if their kidneys aren't working, they're not going to be releasing erythropoietin. So they're going to be in an anemia, So we can release erythropoietin through injections. We can give it to them. And then their bone marrow will start to create white blood cells, thinking that they're getting it from the kidneys. The bone marrow doesn't know the difference. It just says, hey, I got erythropoietin and I can make more blood.
Yeah. Okay.
And then cardiovascular, immune, and neurologic issues and integumentary system issues. We can do things about those to make their standard of living better. And then, and bare minimum, we can give them dialysis, right? If their kidneys are in complete failure, we can give them dialysis and start to relieve the chemicals and stuff in their blood. It's not a great standard of living, but at least they live.
Mm-hmm.
So that's what's going on with that.
Okay.
So it's been like 27 minutes, and we're pretty much through all the notes. You know what I'm saying? So let's go through this again. So what were the major types, not the subtypes? So what were the major disease disorders?
Are you saying like the glomerular?
Well, no. So remember, yeah, glomerular disorders was one.
Okay.
So what was one of the other ones?
It wouldn't be like is it renal?
Yeah, renal disorders was another one.
Okay.
And then there was renal failure. So renal disorders was one, and renal failures was another one.
Okay.
Okay. So if you hear renal failure, is that a bigger issue than renal disorder?
Yeah.
Yeah. So when you level those up, they're different, right? They're like, so acute renal failure is a lot more serious than pyelonephritis.
Yeah.
But they're both serious, but one sounds worse, right?
Mm-hmm.
So we're going to probably be a little bit more aggressive with acute renal failure than we are with pyelonephritis.
Yeah.
Okay, so keep going. What's another one?
Well, I would.
What was ATN?
I don't know what you're wanting.
What was ATN? ATN.
Okay. So we have glomerular disorders. Acute.
Well, just think about the name really quick. What does the name tell you? What was the name?
Well, acute, and then T is the tubular.
Tubular, and N was a nasty word. It means
necrosis.
Necrosis, right? So we know that the tubules of the kidneys are being destroyed
because of a lack of oxygen.
There we go. Man, you're on it. You're on it like a hound dog. It's awesome.
I think I'm getting sick. Can you tell?
I think you just got out of bed.
But my throat hurts.
You should just have a drink of water. Is it hurting like scratchy hurt?
Yeah.
So is that acute or is that chronic?
It's chronic.
It's pathological from this class. So ATN was lack of oxygen. You totally got it. Because of the lack of oxygen, what's happening to those kidney tubules? Specifically from the graphic, it's the PCT. The proximal convoluted tubules are doing what?
The damage to the cells.
Yeah, the cells are becoming damaged or dying off. They're breaking off or sloughing away from their membrane, and they're traveling where? Where are they going?
Into what's the end part? They're
just flowing into the lumen of the PCT, right?
Okay.
If you get enough of them in there, what do?
Lumen occlusion?
Yeah, they get lumen occlusion. They get blocked up, and now you got even a bigger problem, right? Because you have the sloughing off of the cells, which allows stuff to flow into the interstitial fluid. Oh, by the way, the actual tubule itself is blocked. In addition to that, it's going to be pretty difficult to treat that. Okay, so there you go. Okay, so review question. What is a major sign of kidney dysfunction in the body?
Edema.
What kind of edema?
like full body edema?
Full body, perfect. I just want to make sure you understand it, because my gut tells me there's going to be at least one question on the quiz with that.
Yeah.
Give a patient scenario, and they're going to say, "Oh, they got raccoon eyes and swollen feet, and their fingers look like sausages. What's going on?" Right? I mean, you know what I'm saying? Like, they're going to give some weird question like that, and you're going to get all thrown off because you got all this edema all over the place. And instead of being freaked out, you're going to be like, "Oh yeah, I've seen that before. That's just kidney dysfunction. They got something going on with their kidneys." And oh, by the way, they had strep throat last week, and you know what I mean? And now you know what it is. Now you know it's a glomerular disorder. It's acute glomerular disease. Oh, hey, this lady had a massive raging UTI a month ago. What's going on with her? Well, now we know that's pyelonephritis because it's moving up in her, right? She's got an elevated fever complex. UTIs don't associate with that. You know what I mean? Yeah. Women, when they get UTIs, don't get fevers. You get fevers when it gets bacterial or moves up the system.
Yeah, okay.
Hey, you got a 35-year-old guy who's a construction worker who drinks 4 cans of beer a day, smokes, and oh, by the way, now he's got a sharp razor cat hair in his moving down to his urinary orifice. What's going on with that guy?
He got kidney stones.
Got stones, right? Yeah. I mean, that's, see what I'm saying? It was, now that we understand that, now that we've taken this time and broken those down, now we can understand that and see how those disease processes become a whole heck of a lot easier.
Yeah. Hey,
we got an 82-year-old man who had a cardiac arrest a year ago, and now he's got, now he's not urinating like he's supposed to. What does that guy got going on?
Wouldn't that be?
He's chronic renal failure at that point, right? Older gentleman. He probably had reduced kidney function before his heart attack. Now he's had a heart attack where his kidneys were occluded from blood because the heart wasn't pumping like it was supposed to. Maybe for an extended period of time. His body's not responded to it. He's probably in chronic renal failure as an older gentleman who's had a heart attack.
Okay.
You know what I'm saying? Hey, you got an 18-year-old young lady who was in a massive car wreck. It took the fire department 25 minutes to get her out of the car. During that time, she was bleeding. They got some IV fluids in her. It took her another 20 minutes to get to the hospital. She's been out of advanced care now without a blood transfusion for over an hour. She gets to the hospital. They get her revived, and 2 hours later, she's dead in the ICU. What happened to her?
Well, don't you think they gave her too much fluids?
Well, no. They need to give her fluids because she's losing blood, right? To keep her blood pressure up, she's losing fluids. But
they didn't give her blood.
Yeah, they couldn't because they were in the field. They didn't have blood to give her.
Yeah.
So she had blood loss to the kidneys. Anything over half an hour causes what? ATN's probably happening.
Mm-hmm.
Right? Because it's blood occlusion. Those are broken down. They got her revived and they got blood into her and everything. Everything's fine. She died 2 hours later because all of her glomerulus and all those, the ATN, she had tubular necrosis. They can't fix that with blood or fluids. And she died.
Okay. Yeah, because that's a lack of oxygen, meaning blood, to the tissues.
Yep, she had lack of oxygen to those kidneys, and they started to scheme. Right, they started to get less. They couldn't work because there was no blood there to work. Right, they're getting normal saline, 0.9 saline through there, and that keeps them flowing. Right, yep. But they're not getting the oxygen they need to survive. They're still functioning. Right, they're still trying to do their job, which is filter. And they're like, oh, good. We got a great blood pressure, and we got all this fluid to work with. And they're like, but wait a minute, I'm starving to death. I'm not getting the oxygen and the nutrients I need to do my job. Yeah. The little workers in there are like, dude, we're going to go on strike because you guys aren't giving us what we need to eat. They start to stop working or dying in the case of the cells. And then that's ATN based, right?
Yeah.
Okay. So there you go. So now you're starting to see how those disease processes with the different scenarios that could be thrown at us, and how you can kind of identify what's going on, right? If it's got a fever related to it, if there's ever a fever associated with it, what's it going to probably be?
Probably going to be like with what's it called? Now I can't think of what it's called.
Pyelonephritis, right? Because that's the only one associated with fever, right? The rest of these other ones don't have a fever response to them.
Yeah. Pyelonephritis.
Yeah, pyelonephritis doesn't have a fever, right? Okay, but glomerular disorders can have a viral. They can be viral.
Uh-huh.
So someone got like HIV, right? And now they're having kidney problems. What could that probably be? glomerulonephritis because that's viral based.
Mm-hmm. Okay.
You got anything you want to go over?
No.
Okay, let's do this then. Let's go to the back page. Let's go to these back pages and go through this together.
Okay.
Okay, so page number 11 at the very top, it says edema concepts of understanding. A nurse uses their understanding of the different presentations of edema to help determine what is wrong with the patient. Fill in the blanks below with the correct type of edema for the listed condition. So CSF or chronic heart failure. What kind of edema are we going to see with CHF?
Well, if there's blood from the heart.
So if the heart stops working, what's going to get edema first?
The lungs.
The lungs, right? So that's that one. So CHF is going to present with pulmonary edema first. If it goes on long enough and the right and the left side stop working, then obviously you're going to get backflow in the alveoli down into the legs and up into the neck.
Yeah.
But primarily it's going to be the heart first. Okay, what about DVT, deep vein thrombosis? How's that going to present?
Because that's when there's like a clot in the vein.
Yeah, it's deep vein thrombosis. So say it was in the right arm. How would that present?
It would be really like inflamed.
Yeah, it'd be that everything below that point would be very, very swollen, and the interstitial and extracellular fluid would start to build up, right? Because the veins blocked, it can't let that fluid out, and you still have arterial blood being pumped in there.
Yep.
So you're gonna get sausage fingers. Right? Okay, what about local inflammation? How would this one present?
Well, that's just a local.
Yeah, so you're not feeling well, right? You're getting a sore throat, right? Yeah. Well, pull up around your neck, around your trachea. You getting any inflammation of the tissues in there?
Probably.
Yeah, if those local tissues are getting inflamed, it's local, right? Maybe to your adenoids or your glands around your throat, your thyroid and the different structures in there.
Yep.
And maybe some of your glands. I just dropped my Klingon battle cruiser. Dang it. What am I doing? I get working at home and I start playing with my toys again. I get playing with my toys. Hold on, let me. Damn it, it's under my desk. There. I got my foot massager under my desk too. So if you ever hear it moving, it's my foot massager.
Oh, that's nice.
Here's my Klingon battle cruiser. Can you see him?
Yeah.
There he is. Sorry, I got toys. I got some tanks in here too. Hold on. Let me bring. I was painting these. The turrets are not on them right now, but no, I used to teach high school and college, and I used to use games as simulations for like military history. So we would fight the battles, and so I'd paint the models and do different stuff, and yeah. So there you go. So I'm not a crazy gamer. I do enjoy a board game now and again, but I used to do it more as a teacher because I use it to help motivate students to be excited about it. Because learning about D-Day is not that cool, but fighting D-Day with your neighbor is a heck of a lot cooler. And then when you get done, you can learn. You're excited to learn about it as opposed to this is the stupidest thing in the world. Okay, so local inflammation. Think of a bee sting, right? Yeah. Even if they get anaphylactic reaction across their body, at the local site, they're going to get redness and a bump where the bee sting is, or a mosquito bite or a spider bite. You're going to get a local inflammation due to that toxin. And because it's local, it's probably going to relieve itself.
Yep.
What about kidney failure? Our favorite one. What's this one's special feature?
It affects the whole body.
Yep, it's full body edema. Awesome. Okay. Okay, so look down here under key concepts. Renal unit concepts to understand. Nephrotic syndrome. What's that one? Damn it. I just dropped my battle cruiser again.
Protein loss.
Yep, just protein loss, right? And how do we know that? In the name.
Because
what about the name? Gives that away.
With the nephrotic syndrome?
Yeah. How does that name tell you it's just protein loss?
I don't know.
O's go together. O's fight.
Oh, yeah.
Okay. What about acute tubular necrosis?
It's caused by ischemia.
Ischemia, which is what?
the cell, or it's like the lack of oxygen.
Yeah, ischemia. Right? So ischemia is caused by oxygen not getting to the tissues of the kidneys. Okay, and it says there are many different ways. Pick your poison. Pick your disease process that keeps happening. Okay, acute renal failure. Anything with that? Reversible. It is. We can do something about it. And then what about chronic?
It's permanent.
Yep, it's permanent. We're going to just be doing palliative care on that one. Okay. Differences between signs and symptoms of UTI and pyelonephritis. You don't have to look at this now. You can tell me what the differences are.
Local inflammation of bladder, urethra, and ureters.
Yeah, it stays local down at the bottom of the urinary system, right? Where pyelonephritis, what's happening there?
Fever, chills. It's systemic.
Yeah, it's moving up the urinary system, causing fever and chills. You're getting a larger immune response.
Yep.
Okay, blood pressure regulation. RAS. Here we go. You can explain RAS for me?
Yep.
Go for it. Kill it.
Okay, so
you got so excited yesterday about doing this with your little flashcards. So excited to see this again.
Okay, so the kidneys release renin.
You're totally looking at your flashcards right now.
I know, I'm pulling them out.
What was that?
I'm pulling them out so I can look at them again.
I can't see you because your camera's not working. I can just hear the flashcards moving.
Okay.
You're doing awesome.
I'm looking at my flashcards.
Okay, we start at the kidneys, right? We basically start and end at the kidneys, correct?
Yeah.
Okay, so start at the kidneys. What's going on there?
Well, they're releasing renin.
Yep.
And then the liver is releasing angiotensin.
Angiotensinogen, right?
Which becomes angiotensin 1.
Yep, when those guys meet up, where do they meet up?
In the blood.
Yep, in the blood. That's their high school hangout. They want to meet in the blood. They go, hey, renin, hey, angiotensinogen, I'm going to meet you in the blood. We're going to hang out.
Okay.
And when they hang out together, they become what?
They go to the lungs.
Well, they become angiotensinogen in the blood, and then they go, hey, man, this isn't a very cool place to hang out together. Let's go to a dance club. They go to the lungs where it's like, and then what happens?
And then the angiotensin 2, or no, they release, isn't it?
In the lungs, the DJ's name is Ace.
Okay. Angiotensin converting enzyme.
Ace is throwing down the beats at the lungs, and there's like this big dance party going on, and angiotensin 1's like, yeah, this is awesome. Ace like throws down the beats, and then what happens?
So then they go to the
angiotensin 1 gets their dance moves on, and they become angiotensin
2.
Yep, because Ace throws down the beats in the lung.
Yep. And then from there they go, and it becomes aldosterone.
Yep. So angiotensin 2 flows to where?
The kidney.
Yeah, because they went to the club and they had too many drinks.
Mm-hmm.
They had too much of a party with Ace up in the lungs, and they're like, dude, we're drunk. We can't go home drunk. So what do?
They go home.
They go back to the kid. They go kind of home. They go to their neighbor who they like, who's their friend, and say, hey, dude, we got to hang here for a while because our parents are going to see us all tore up. So can you help us out? So where do they go hang out? They hang out at the neighbor's house. Who's the neighbor?
It's the gland.
Adrenal cortex.
Okay,
which is the neighbor of the kidney, right? It sits right on top of the kidney. It's the neighbor. So angiotensin 2 goes to the neighbor's house,
yep,
which is the adrenal cortex. And
which
the adrenal cortex
aldosterone.
It's released as aldosterone, and then it can do its job, which is to do what? What's the whole point of doing this?
Increase the blood pressure.
Yep, raise low blood pressure to high blood pressure. Yes, excellent. Raising low blood pressure to high blood pressure. And there are 3 processes that have this work. What are they? There are 3 distinct body processes or physiological processes that raise blood pressure for us. The first one is the RAS system from renin all the way to angiotensin or aldosterone, excuse me. Then what's the other in the RAS system? One of the midpoints allows us to also raise our blood pressure.
With the sodium?
No, aldosterone causes sodium uptake in the kidneys. That is definitely what's happening. But angiotensin 2 does something entirely by itself that raises blood pressure.
Oh. Doesn't it have to do with the calcium?
It constricts the blood vessels. It's a vasoconstrictor.
Angiotensin 2?
Yep, angiotensin 2 all by itself is a vasoconstrictor. It causes the blood vessels to constrict.
So what has to do with the calcium?
Let's look at the RAS system again. Oh, that's in the liver.
Okay.
Oh no, GI. It's in the GI tract. Let's look that up because I honestly can't remember. I don't want to say it wrong, but I know what's happening in the GI tract.
Okay.
It's something to do with GI. Okay, and we'll have to look that one up. I'll look it up again because I can't remember off the top of my head. And I'm looking at notes here. Okay, what's the third system that causes blood pressure to come up? And it's not the RAS system at all. It has nothing to do with RAS. Posterior pituitary.
Oh, because of the posterior pituitary.
What does the posterior pituitary secrete?
Hormones, but it secretes
ADH, anti-diuretic hormone.
Diuretic hormone.
Which also tells the kidneys to hold on to sodium. So a totally separate system says, hey, blood pressures, we're getting really, really viscous blood. We're losing fluids. So the posterior pituitary secretes ADH, and the ADH goes down to the kidneys and says, hold on to the sodium, keep the blood fluid levels high.
Yeah.
You have 3 systems there. Angiotensin 2, vasoconstrictor, aldosterone, which says hold on to sodium, and the posterior pituitary secretes ADH, which also tells the kidneys to hold on to sodium, and those all drive blood pressure up.
Okay.
Okay. What's the system that drives the blood pressure down? I now have high blood pressure. How does that work?
That would be, isn't it the beta?
It's not beta blockers.
No.
It's that Roman word. It's that Latin word. Starts with an N. Natriuretic hormones.
Natriuretic. Okay.
ANP and BNP.
ANP and BNP. Let me write these down.
So ANP stands for atrial natriuretic peptide.
Okay. They lower the blood pressure.
Yep. With a high blood pressure, these things are going to bring blood pressure back up. So ANP functions to block aldosterone, and it also inhibits renin. It blocks both the start and the end of the system when blood pressure is high. Then what does BNP do? My ventricles are too stretched out.
Yes. Okay, these are coming. Yes.
Okay, my ventricles are too stretched out. So BNP is secreted. It is an indicator or a marker in the blood that says you are in heart failure.
Uh-huh.
And it's a byproduct of being stretched too much. Okay, so ANP and BNP presence, they block aldosterone, they inhibit the renin, and those things stop the RAS system from working at all, which is going to drive blood pressure down.
Yeah. Okay.
Okay, it's 8:51.
Okay.
What do you work tonight?
Yep.
What time? 7 o'clock?
6:30.
Are you excited?
No.
Come on, be really excited. I'm excited. Well, listen, I'm gonna cut out if that's okay, and then I'll give you a chance to get some rest. And I think your throat will feel better. Drink some fluids, get a good sleep. I think your throat's going to feel a lot better.
Yeah, I'm going to drink a emergency vitamin C thing.
There you go. That would help too. Yeah, that would also help. You can smoke some cannabis. I've heard that's for a sore throat.
What is?
I said you could smoke some cannabis.
Oh.
I heard that's great for everything. I heard if your feelings get hurt, you just smoke a joint, you feel better. You get cancer, smoke a joint, you feel better.
Yep.
You get a little sore throat. Hey man, little THC in your vitamin C, you'd feel good.
Yeah. I would be, feeling good.
You'd be flying high.
I'd be cured.
And you'd be sleeping like a baby.
Yeah, I probably would never wake up.
Well, maybe you're kind of small. We give you a small dose, you'd be all right. Okay, listen, I'll let you go, my dear.
Okay.
Okay, have a good sleep, and then if you need to get a hold of me, just let me know.
Okay, sounds good. And then we'll talk tomorrow about meeting up.
I work tonight 12 to 8, so guess what? We can all feel bad together.
Yeah.
So when you're at work, go, oh man, Chris is sucking up too.
Yeah.
Just remember, you're not the only one sucking wind.
Yep.
Okay. Have a good day, my dear.
You too.
Okay, bye.
See ya.